Good afternoon. We still have a few folks in the line, but we'll have them come through while I'm speaking, not Dr. Kushevsky. So, my name is Kevin Dirksen. Welcome to the 2018 Kurt Holzgang Visiting Scholar Lectureship. I serve in the role of Senior Ethicist and Director of Ethics Education at the Providence Center for Healthcare Ethics. You could take a quick moment and silence your pagers, cell phones. The session is going to be recorded. Established in 2002, the Curtis Holzgang Visiting Scholar Lectureship is a program of the Providence Center for Healthcare Ethics and supported by generous benefactors of the Providence St. Vincent Medical Foundation. If you weren't able to join us for medical grand rounds this morning, Dr. Kushevsky will be offering the same talk at Providence Portland tomorrow at 8 o'clock on Who is My Neighbor in Catholic Healthcare, Caring for Undocumented Immigrants in Our Community. Before I introduce our speaker, in the tradition of Providence, I'd like to share a reflection by Parker Palmer. The word soul is important to me, but the word points to a mystery known by many names, for which no one has the true name. Secular humanists call it identity and integrity. Hasidic Jews call it the spark of the divine in every being. Thomas Merton, true self. Quakers call it the inner light. Buddhists call it big self and no self. If there is a universal word for it, perhaps it's the being in human being. What you call it doesn't matter to me, but that you call it something matters a lot. When we fail to name it, we are more likely to treat each other like objects to be manipulated or empty vessels to be filled with someone else's agenda for our lives. Let's do whatever we can to remind ourselves of the sacred being in all of our brothers and sisters, especially at a time when entire groups of people are being portrayed as subhuman. Elsewhere, Palmer also explains, the soul is generous. It takes in the needs of the world. The soul is wise. It suffers without shutting down. The soul is hopeful. It engages the world in ways that keep opening our hearts. The soul is creative. It finds a path between realities that might defeat us and fantasies that are mere escapes. All we need to do is to bring down the wall that separates us from our own souls and deprives the world of the soul's regenerative powers. Palmer's words remind us that one of the prerequisites for the course offering today is a keen sense of self and empathy. The rest is merely details. And now it is my pleasure to introduce our visiting scholar, Dr. Mark Kushevsky. Dr. Kushevsky is the Michael I. English Professor of Medical Ethics, Director of the Neiswinger Institute of Bioethics and Health Policy at Loyola University Chicago Stritch School of Medicine, and is a past president of the American Society for Bioethics and Humanities. Dr. Kushevsky is a leader in the field of clinical ethics, publishing widely and at times provocatively in the literature for over 2 decades. This afternoon, Dr. Kushevsky is not donning his specialist hats in immigration issues or Catholic social justice and healthcare, but rather his role and expertise in a long career as a clinical ethicist. Dr. Kushevsky is the director of the Ethics Consultation Service at the Loyola University Health System and has trained scores of aspiring ethicists through the Neiswinger Institute's graduate education programs in the last 2 decades. We are lucky to have this opportunity to think through some challenging cases with him today. Would you all please join me in welcoming Dr. Mark Kushevsky?
Thanks for that kind introduction, Kevin. And it's great to see so many people here interested in this topic. I take it that this, when you hear about difficult families, it strikes a chord, and people want to discuss that. And it is an honor to be with busy clinicians who take the time out to reflect on these kinds of issues and on how they can serve their patients better. This morning I met Dr. Holzgang, who this visiting scholar series is named after. And he was just a reminder of being a critical care doc in the 80s and the early 90s when there really was no field of bioethics, and clinicians really got together and toughed it out. And it's so wonderful to have these resources here, like you have in the Center for Healthcare Ethics, with people like Kevin and Nick Cockler who can come and reason it through with you. But in the end, what we've really done in having these resources is to systematize thinking it through. That the wisdom is out there. It's a matter of us figuring it out, how to bring it to bear on these situations. That's what we're going to try to do today. I'm going to talk for a few minutes about some of the issues that are being raised and a little bit of some of the possible ways to respond to them when we're dealing with difficult families. Then I want to get to some cases, and I really want to hear your voices. And so I hope you will participate in getting with it. One of the cases was given to me by Kevin, and I understand that some of you may have been involved in it. If anybody's here involved in it, I certainly hope you'll pipe up. But to start us in thinking about the family and families that really are somewhat challenging to us to deal with, a variety of scenarios are fairly common that we run into. One is where they simply are insisting on potentially inappropriate care. We've started to get away from the word feudal care, but for so long we did use that term. But the idea of care that we really think brings virtually no benefit to the patient, but yet families are saying to us, keep doing it, or if they go into cardiac arrest, do it no matter how awful you think the situation is. And we run into a fair amount of that, and it can still be fairly challenging virtually every time. What we're starting to see is, some of the things that people believe or are hypothesizing are somewhat exacerbated in the age of the internet. Where families come to us with hypotheses about various aspects of this. Sometimes symptoms, the one I've listed here is that the patient is dwindling and has a terminal illness, and we expect to be dead fairly soon. And we say to them, we really don't think we should place an NG tube or a PEG tube. And the family, though, starts to come up with ideas like, but wait, the problem is she's just not strong enough to eat. And if we could get her strong enough again, and so she needs to eat to get strong, but she needs her strength to eat. And so then we'd end up driving things with these kind of hypotheses that are fairly suspect from your viewpoint about the symptoms. And of course, then they come up with whole other possibilities for what the illness is about, and they bring that to you, and they come off, sometimes even print out the stuff from the web, and are fairly convinced, and really kind of challenge you to go to some great lengths to show that this is not the case, and are often fairly resistant, and trust is breaking down. I'm sure that I could tell by the looks of recognition in the audience that this is a problem that you encounter with some regularity. And then there is the thing that is, we're starting to see more and more of it at our health system, whereas people are staying at the bedside. We often want an engaged family. We like families to visit, when families are disengaged, it's difficult. But families standing at the bedside really making very minor decisions about things that are being administered that we consider fairly routine at the bedside, medications, blood draws, all these sorts of things, and micromanaging this and driving the team absolutely wild at the bedside, because it's very hard to get a plan that everybody's sticking to from day to day. Each day when you show up, it seems like that they've got a different idea. You talked to them yesterday about the pain medication, but today they've got a different idea when you show up, and it becomes very difficult for the caregiver. And the challenges that can raise, just the amount of time required to tend to those small interventions, that if every day, from one day to the next, you can't get an agreed upon plan for these minor interventions, you've got to go through repeat procedure daily, and it takes a lot of your time and your energy, and then sometimes the family has a favor. They'll only take the explanation from one particular member of the team, and so that person becomes really bogged down and the time drain on them. And of course, the energy drain owing to the constant friction, right? So sometimes the family becomes fairly defensive or distrustful, and that is a hard environment for you to work in, right? It's hard enough to do your job as it is with the time demands. When you're dealing with people who you feel are challenging you at every turn, it becomes an even greater drain. You can start to dread coming to work in the morning, right? When different units have different strategies, sometimes for rotating nursing staff on a particular patient or things like that. But there's all sorts of complications that happen off that. And then there's just this question of, do we have to listen to them, right? Because sometimes before the patient lost capacity, they told us some things that they wanted, and we think we're instituting a plan of care that the patient would want, and yet these family members who are the supposedly appropriate surrogates start telling us something different. And so the ethicist is often asked, do we have to listen to them? Because we think we know what the patient wanted. And so the relationship of what the wishes the family is expressing to the relationship of the patient, and should we consider this what the patient would want at that point? And so all of those things kind of send us into a difficult cycle with these family members. And it can become a cycle, right? This can actually get worse on a daily basis, because then when your energy is drained, avoidance of the family can start to happen. Then they feel they need more control, so they ramp up their interventions to try to stop things, and this can get worse and worse. And so lots of things happen. And so, now you're hoping that I will give you the easy answers to this, right? So brace yourself. The next slide is everything I got on this from scouring the literature. And so I hope it's not underwhelming. But the literature tells us that there's 3 things we can try. One is to listen and respond to the family members. So it's telling us while our instinct is avoidance, this will get easier if we start training ourselves to go toward them. And so make sure that they feel that we are listening to them. Don't start talking until they've finished talking, so that they feel that we at least give them that much control. That's one hypothesis, that if we do that and we address each concern, the idea is it may take us a lot of time, but the more we do it, maybe the more that behavior on their part will decrease. One of the other pieces that we actually counsel when we train ethics consultation, we do a lot of simulations at Loyola. We practice doing ethics consults, is make supportive statements. Make them early and make them often. And so just saying things like, this must be really hard for you. And as often as possible, say that to the family members. Or whatever your line for a supportive statement is, repeat it and do it often. Sometimes, and I will say, I can verify that nothing's 100%, but this often gets surprisingly good results. Sometimes when, starting an ethics consult, I turn to a family member who's got a reputation for being difficult and say, I'm so sorry, this must be really difficult for you. And they sort of wince for a moment and say, well, thank you. Nobody's ever said that to me before. And they start to explain how difficult it is for them. And it can at moments, you could feel the guard come down, that all that defensiveness is because you're actually trying to let them know, I get it. This is difficult for you, right? You have to be careful with that. You have to get your best technique. Something like, this must be very difficult for you is when I kind of say, one thing we can't say is like, I understand exactly how you feel, right? Right. That won't get it done, because that's actually disempowering of them. So one has to practice to get the kind of phrases that work for you. The third possibility that the literature raises is to explain key tenets of medical ethics as often as possible. And excuse me for the typo there, but some of it is. If we're asking about the relationship of, if you're asking the ethicist, what's the relationship of this family's wishes to the patient's wishes? We have to listen to the family. One thing is to often say to the family, Nana, what we're trying to figure out is what would the patient want? What would your mother say if she could sit up and talk to us, right? That's what medical ethics is after. We're after substituted judgment. You can even give them technical terms if you want, as long as you explain what they are. And so now you understand that's what we're after. We don't want to do what we want to do. We want to do what your mother would want to do. Now, if she could hear everything we just said about her condition and the treatments. What would she say if she could sit up and talk? And repeat things like that. The other one that's kind of nice in this is the benefits and burdens. People are asking for peculiar treatments. Talk to them about, well, that's got a certain burden to it if we do that treatment. This is going to cause some pain and suffering. You might break some ribs in case of something like CPR. Talk about what are the potential benefits. Well, it might prolong life just a short period of time, but it's not going to have the benefit of curing or getting her for a long period of time. And just keep explaining these kinds of concepts as part of the technique. That's everything the literature's got for you, okay? So it's not, it doesn't sound like a can't miss by any means, but the idea is, these are often called missed opportunities, that when we get into that downward cycle with families, that spiral, we start missing opportunities to do any and all of these three. And that's one hypothesis about why these situations deteriorate a little bit. All right, so why don't we try actually your case first? And I was given this one. And it says, Min Jung is an 80-year-old Korean-speaking woman with a history of stroke, dementia, and prior hypoxic brain injury with a PEG tube and on chronic tube feeds, who presented with severe dehydration and acute hypoxic respiratory failure due to aspiration pneumonia. The daughter's present and singularly focused about resuming tube feeds and demonstrating a limited understanding of the patient's severity of illness. Acutely very tenuous respiratory status and sepsis, to the point where she was refusing to allow the patient to have medications that were ordered and lab testing to ascertain the cause of her more pressing medical problems. The team wonders about the appropriateness of arranging care to be carried out when the daughter was not present, or some other alternatives. Any of you on this treat this patient? Do I have anybody in the? Okay, so a few of you were here. Okay, okay, very good. All right. So, just general impressions. What do you think? And then, but those of you who treated the patient want to jump in at any points, by all means. What do you think?
I just asked, so was there a medical directive from the patient?
I take it probably not. Would anybody who treated her know the answer to that?
I believe
Oh, there was. And any idea what it might have said? Okay, so you thought that the patient was DNR based on a directive that she had provided us. Okay, well, we got lucky. Okay, good question then. Because I would have guessed this patient would not have had one just in your typical experience. But good question, which is why when you're doing a difficult case, you want to do your checklist, right? Because you never know. So we at least have something. We have an expressed wish by a patient to be DNR, DNI. Okay, good. Other responses?
Is the daughter aware of the patient's long-term, is the daughter aware of the patient's poor long-term prognosis with or without treatment?
Right, that's a great question. Is she aware? Because she seems pretty focused on keeping her alive via tube feed, and it's not clear why, right? Does she think she's going to get better? That's a great question.
I was just saying, is there a language barrier, essentially, the daughter not understood?
Yeah, okay. Okay, so the daughter speaks fluent English, so we don't have to worry about a language barrier with her.
What about the cultural issues related to
Mm-hmm. Okay, so and what's your hypothesis there in looking at cultural issues? What kinds of things do you think might be in play?
how do you show one as a daughter that you love your mother, you do everything possible, maybe feed people, maybe that's more of a nurturing that comes out. I don't particularly know, but I want to know how they see, the relationship and what they are, expecting her life to go like in that culture.
Okay, good. And so you've raised several points. I'm just going to repeat them so that they pick it up in the recording. And the points you made were, one, how did they see the relationship to the parents? Like, Does the daughter think that this is actually her job to keep the mother alive and advocate for more things, right? Is that what she thinks of as a good surrogate? And the other piece was the symbolic issue of the feeding tube, right? Now, is that feeding tube seen as nurturance in the same way that spoon feeding would be seen as, and if so, maybe we can address that in some way, right? Is that, should she be thinking of a feeding tube as nurturing feeding kind of thing? Yeah, that's a great question.
My comment was related to that. I want to know if the daughter was caring for her mother in her home, if this was her full-time sort of endeavor, and how long that had gone on. And also, if there were other siblings in the family. I assume there's not a living spouse, but that's an assumption, and maybe the circumstances around his death.
Yeah, good questions. And, you know, and in various cases, we see, we raise that question, and it's always good. When we do simulations, one of our checklists is, does the ethics consultant ask about, make sure that the person we're talking to is the appropriate surrogate? And so asking about, is there a husband and are there other children? Because depending on your state law, I'm not sure what it is here in Oregon, the other children may have similar standing. You know, sometimes it gets you more than you want, too, in these situations. You find a husband who is semi-cognizant at another nursing home somewhere, right? And now we've got to talk to him on the phone and try to figure out whether, in fact, he's able to make decisions for her, and that can be very difficult.
Also, just looking at that, the daughter only wants to give her 2 feedings, doesn't want to give medications, or so I was seeing that the daughter only wants to give 2 feedings, doesn't want to give medication, doesn't want to do blood tests, and I had offered to let the daughter do 2 feedings and comfort her.
Good question. Were there discussions about comfort care with the daughter?
My comment is similar to what others have said, just the lens of not so much how little does the daughter know about medicine, but how much does the medical team know about the patient and family.
Okay. And say more about that.
Some of the things were already raised, things about what does it mean to the daughter to make various decisions for her mom, or the things she wants to do for her mom. What might their religious or philosophical point of view be around this time in life? Are there important people that aren't here yet? Just all kinds of things that we should know as care providers about the folks that we're taking care of.
Okay, good. All right. Is there
Okay, so something that's unclear here, maybe because you don't know, is how much the daughter had a chance to hear about what the mother had expressed wanting. And my background is mental health rather than physical treatment. And so, and also I'm a family member of somebody. So I think terror that this woman's facing, that her mother might die. And is it possible for somebody to take her aside and talk about, do you know what your mother wants? Do you know that whether if the circumstances she's going to die, it's just a matter of how many minutes or hours, and just talk through the implications of this, of course, account for things people have brought up like religious beliefs, and see if, you know, it empathize with how frightened it is that she might die. Just see if giving her some care could help to with this book.
All right, good, excellent point, right? And might want to utilize some of your pastoral care resources at the facility to have them come by and check on her and ask similar questions, whether they can hook her up with any resources from her own support network as well. All excellent points. Good. Any other thoughts? Yes.
I wonder, staff check, when they staff check how the daughter sees the food.
Mhm.
Because more function will be.
Okay. Right, very good. And a very similar point here, right? What is the meaning of that feeding tube? Is it nurturants or is it nutrients, right? And if it's nurturants, we want to talk to her about ways that you can continue to nurture her, even if we are not putting artificial nutrition into her.
Even though it may look so small things, but I think that sometimes two different worldview clashes on this issue.
Right.
Because it's a treatment method that it's a food to the ordinary people.
Right.
For most Asians, it's more than food. So,
And when you say more than food, in what way, how does that work?
that's the kind of connection always.
Okay.
So in Chinese world, family is the shikku means people who share the same food.
Oh, okay.
So food is more than food.
Right. Okay, yeah. Very good, thank you.
There may be kind of a secret in here, I don't know, but we tend to think that when a family wants to do something like using tube feeding, that they're the ones interested in aggressive care. And here it may be that, I don't know, from the case history presented, but maybe it's comfort care that the daughter wants. I would want to ask at least, what's the team's goal in ordering medications and lab testing? If the medications are like morphine for comfort, that's one thing, but if they're antibiotics, that's another thing. And what lab testing and what about ascertaining the cause of the more pressing medical problems, what's the goal underlying that? Seems like maybe the conversation really hasn't happened, and there may be a misunderstanding of the daughter's interests that we haven't noticed.
Right. Yeah, no, that's excellent points. Yeah, and it's difficult to know exactly what the daughter's goal is, as you point out. We don't really have that on the table. Is it life extension, or is it just symbolic nurturing? Is it expressing an advocacy role? Because there is at least, with her attention to simply the artificial nutrition and hydration, it doesn't necessarily go with life extension, right? And yet maybe the team thinks it might, and maybe that's causing some of the confusion around the lab testing and things like that. Yeah, good. One question, I take it that so this case was given to me, I take it that the last sentence is to some degree just a question around, suppose the daughter isn't there certain hours of the day. Can we just come and do the stuff then, right? What do you think about that? It's an interesting question.
Surrogate decision-making has kind of gone out the window with that.
Right, yeah, it's not a good strategy from the point of view of surrogate decision-making, right? It isn't a bad strategy from the point of view of reducing tension, right? I mean, it makes your life a little easier, and certainly it's hard to fault people for doing that on a daily basis for small things. And again, as a strategy, maybe not so bad initially, but it shouldn't be a substitute for asking a question about the goals and the bigger meanings. We want to have that conversation too, right? We don't want to just sidestep that conversation completely. All right, so to recap, what do we got here? We got some suggestions that we want to have a conversation with the daughter. We want to make sure that that she is the only person who should be there. We want to check to make sure there's not siblings or a husband or a spouse of some sort who should be there. We want to talk to her about any support she might need, right? She's been caring for her mother for a long time, and we understand that the loss of her mother could be potentially very, very difficult, and how can we help support her through that? So we want to have those kinds of conversations. Then we want to ask her very straightforwardly a why, about why she's focusing on the feeding tube. Is it because she believes that everybody has to have that because it is a way we nurture somebody? She might blurt out, if you don't do that, she's going to starve to death, right? And then we have to have a longer conversation about the meaning of starvation, right? And how a person, when they're dying, isn't necessarily starving, and we can alleviate symptoms and have that kind of conversation with her. And so there's all of those possibilities. And then we want to see what the goal she is. What does she think will come from continued treatment of her mother versus some other possibilities such as comfort care, right? See if we can get her to tell us about any of those kinds of things. And we want to make all of our supportive statements and continue to let her know we're very concerned about her, and hope that gets us at least somewhere in an initial conversation, right? I have no idea how this case has gone. Does anybody who's got some experience want to share a little bit about that? So you've got a good outcome. Yeah. Awesome. Well, that's great. It's interesting the suggestion early on that the surrogate decision maker might be at issue. It's an interesting one. And so nice pieces of the checklist, right? Asking about an advance directive. And I take it the son was named in the advance directive as the appropriate surrogate. Yeah. Well, fantastic. And so good. So we ended up with a good outcome here. And it is one of the things that an ethics consult can help with sometimes when things are going south pretty quickly. The ethics consultant would run down this checklist quickly of, is there an advance directive, who's the appropriate surrogate decision maker, and then get on to these more subtle questions that were raised here. So nice. So sometimes there is hope. It works. Do you want to add anything to that? How does the team feel about the situation in retrospect? Fantastic. And in the end, did anybody say thank you to you for your hard work on this case? Wow, this case had everything. You even got a thank you. I usually ask that question because one of the things I think that is tough for morale is when we talk about cases that are ethics cases, even when we get a decent outcome, you feel a little beat up at the end. And it's good for if not the family member themselves, at least for us to thank each other for your hard work. And so thank you for being diligent and sticking with that and getting to a good place for that family. So good, awesome. Well, thank you for sharing that with us. Slightly similar case, and this one came to us at Loyola's health system. And one of the things that happens when you're an ethicist, if a case bothers you for a long time, you end up publishing it. It's just, so you can tell that this one bothered me probably. The patient, Mrs. O, is a 55-year-old woman with metastatic colon cancer. The attending physician and treating team are clear that they believe the patient is actively dying. She is unconscious most of the time, but according to the patient's family members and some reports by members of the medical team, she has had an occasional recent moment or two of relative lucidity. Her 2 adults who spend most of the day at the bedside report that these moments are few and rapidly becoming fewer each day. The patient also has a husband and adult son who visit for a couple of hours each day. The plan of hospital care is in some ways relatively clear. The patient's husband is clearly the appropriate surrogate decision maker when the patient cannot speak for herself, and in initial discussions, he agreed with the attending physician that comfort care is to be pursued and that the team should no longer attempt to cure the patient's cancer. There's a DNR order in the patient's chart. Things are sounding pretty good so far. There has been some deliberation about appropriate placement, whether the patient should remain where she is in the hospital and be comforted until her death ensues, placed in an inpatient hospice bed, or discharged home with hospice care, if possible. Given her prognosis of only a very short time to live and the difficulty in transferring her out of the hospital, an inpatient hospice bed would have been ideal. Unfortunately, the patient's insurer declined to authorize inpatient hospice care, thereby eliminating that option. Of particular concern is that the patient's husband and son have some idiosyncratic ideas about the patient's condition and care, and they express them in a confrontational manner. For instance, the patient's husband asserted that he did not believe the patient's abdominal discomfort was caused by metastases, but by an echinococcus infection, and he wanted treatment for it. Later, as the patient lost interest in food, the patient's husband and son wanted albumin given to her so that she would get strong enough to eat. They believed that she was not eating because she was not strong enough to do so. So the physicians found themselves consistently trying to fend off requests for tests and treatments that were not indicated. At times, these refusals greatly frustrated the husband and son, who would then suggest that they wanted the goals changed to life extension if they could not get their way. The attending physician called for an ethics consultation. All else has failed, call the ethics team, right? What are your reactions to this case? In many ways, very similar to our last one, but a slightly different scenario.
I want to know more about why do you think this is caused by the point against it, infection?
What the husband was thinking, where that came from, and learn a little bit more. Listen to him about his theory or his concern.
Right, and that's, if I've got that right, I'm not a physician, that's an infection caused by a tapeworm, right, or something like that, isn't it? Yeah, so he's actually thinking there's a parasite involved. Yeah, that seems like a pretty idiosyncratic thought. So is it because she's had one before? Did somebody else in the family have one? Where's this coming from? That's worth asking about. Other thoughts? The mic's right behind you if you want it. Okay. No, okay.
What was going on with the daughters?
And what do you mean by what's going on with the
They were
daughters?
there most of the day.
Mhm.
I'm wondering why the daughters didn't have any input. They were there most of the day. What were they doing?
Yeah.
They talked to their dad.
They would, and he would dismiss them, and they'd get mad at him. But he's, by the surrogate statutes, he's the first line of default for the surrogate. But yeah, he was fairly dismissive, raising a question among some of us whether males rank higher in the family than females, as one possibility here. He takes the son's opinion seriously, not the daughter's. They all live in the same house, by the way. This is a Polish immigrant family that comes to us with a certain cultural background, and the daughters don't seem to merit too much. Other thoughts?
All right, this is the chaplain's point of view.
Mhm.
This story has grief written all over it. This guy is grasping at crazy straws because he's not
Sure. And until we get to pastoral care, we want to make supportive statements, right? Because yeah, I think you're saying something that has some potential here, that cognitively, he initially accepts that this is a dying patient, and then he wants to do something, right? And so he starts doing, and he gets very engaged. And so, yeah, ways we can allow him to express what he's feeling or what's going on may help. Pastoral care, we got them involved. Unfortunately for us, some family members are better at opening up and doing that process than others. And so we didn't end up getting great results from him by using that, but it's definitely one of our first lines of defense.
Yeah, I'm wondering if anyone has really talked to the family about what the adoption process looks like and what it might look like for a particular illness. We might think that it's supposed to look a certain way and are confused maybe about maybe some of, as her illness progresses, what the symptoms mean.
Right. Yeah, and even say more about that. Hold on to the mic. Even say more.
Well, I think that many of us, unless we work in another field, we don't see people dying, see it on TV, we don't actually witness what it means for someone to stop eating or for somebody to become a little more lucid and then not be lucid for a longer period of time.
Mm-hmm.
And so maybe to have someone come along and describe maybe what are some of the things that the mother might experience in the next days to hours to weeks might be comforting for them to put meaning to their experience.
Yeah, thank you. And that's a really good point. I mean, it is one of the possibilities here, right? That along with his grief and wanting to do something, this doesn't look like they think death is supposed to look like. So they're trying to get it fixed to look like that. It's supposed to look comfortable with the person eating their favorite foods, right? That's what they're thinking. And as you're pointing out, that isn't necessarily how this goes. When they lose interest in food and that kind of thing. Yeah, important. And probably we're going to have to reiterate that a bunch of times. That's probably not going to be a one-time and they get it conversation.
So I'm going to come at this from a really different lens, a care management lens. We've got a physician lens, we've got spiritual care. So from a case management point of view, I agree with everything. The grief angle, what's going on culturally in this family, certain decision making, I get that. But another lens is, this has written all over it that this patient is actually on level with care. She's ready for hospice care. In a place that doesn't have every test available to them, every conceivable treatment, especially at such a high level medical center, there's everything that can be done. So from a case management lens, I would go back to that insurer. Even if I needed to get asked to talk to their physician director and get my physician director on the line, and I would push for a different decision, and even then looking at some other options within our control, if that's still a no, getting these patients the right level of care, because then they know how to shepherd patients through and families through the dying process. So,
Right. Yeah, no doubt. And we have a couple more hands. You must have sparked something. We see hands.
In agreement with that, as well as I've seen multiple times where patients, they say, their goals of care are comfort, hospice. They want to do that until they figure out that when they go to a SNF or whatever other facility, they have to pay for that on hospice, and they don't feel comfortable having the patient come home. And so there becomes this sort of seeking way of how can we keep mom in the hospital.
Yeah, and that's a great hypothesis about what's going on with this family, is actually a fear of taking her home, right? Because and that could be for a variety of reasons, that they feel panicky at the thought of managing her while she's dying and fear that hospice care will only be there several hours a day and they could be alone with that. Or even cultural beliefs. I mentioned Polish immigrant family. My Polish grandmother didn't want anybody dying in the house because that ruined the house. You actually, spirits are there and you might have to move out. Yeah. And so even something like that could be done. But there might, something about not taking her home might be driving this process for them. They think they got to take her home unless she's getting treatment. And so to address that she can stay in the hospital at least, what is one option here. Was there a hand over here?
So in other hand, with a different background, like in other cultures, people rather have their members die at their home.
Mhm.
So it's a challenge to them to send anyone to the hospice. It means you are abandoning your member of your family.
Mhm.
So I think everybody had to put their heads together and think how we can comfort the family and let the member try to if it's here, this is how much it takes to live a life and sending someone to the hospice and other hand to other people. That is the last option. So it's very challenging to anyone of the family member let the person go.
Mhm.
So that's like both the abandon someone of your family, which abandon life, they will never forgive themselves.
Sure. Yeah, no, and that's key, making sure that people play the surrogate role the way they think it's supposed to be played. And so some reassurance to them, often talking in terms of many good families that we know would say or would do this, and pointing out the other option, so that they know that families are respected who do something differently, might open some doors for them as well.
One of the things that I sometimes find myself saying in genetics consult like this is testing out some hypotheses as we continue to gain facts and figure out what's going on. And as a sort of curious observer of this healthcare thing, not a doc, not a nurse, not a family member, not a patient, what I'll find myself offering sometimes is that this may sound to me like this is a family who is wrestling for control amidst a situation they might have very little control with. How actively is she dying, the overall prognosis, the inability to have her home, whether that's desired or undesired. I sometimes hear requests for things like albumin as a second pillow, and it's an attempt to try to wrest control, to provide care, and that in some of these cases, it may even be affirming the good work that the team is doing by trying to understand these as not treatment requests or demands, but the family evidencing the desire to show sympathy and comfort, and try to have some control, and altogether uncontrol.
Right. Yeah, and so then the physician in this case tried to cede them little control over choices that she didn't think of as particularly consequential in an effort to try to do that. It didn't seem to alleviate too much of the situation, but it doesn't aid our understanding to think of them as feeling as if this is out of control.
So I'm a primary care physician in the community who trained in this program 10 years ago. So my comment is for the benefit of the house staff. One suggestion I might make for getting some context is reaching out to the patient's primary care physician or the oncologist who shepherded them through the treatment phase of their disease. I have patients come into this hospital often who are gravely ill and subsequently pass away, and very rarely does anyone reach out to me as a PCP who might be able to explain some of the husband's bizarre behavior or the relationship between the daughters and the son that might give the inpatient team context to be able to approach gingerly and get the train in the right direction.
Yeah, thank you. That's an excellent point. Any other thoughts?
I think cultural awareness is very wonderful thing to do. But then while I'm looking at these two cases, I realized that the patient names are like foreigners, not American names. And this one was Korean, and the second one was also Mrs. O, sounds like Korean name also.
Oh, she's Polish.
Oh, Polish.
Yeah.
Okay, yeah. So maybe I'm just saying, who is the common Korean last name? So when the provider doctors get care, and if they cannot communicate things in English, the doctors or their provider can be confused, because of the communication difficulties. Sometimes the difficulty can be considered a cultural difference, but actually I don't see any cultural difference between those two cases.
Thank you. It's a very interesting question what role culture should play in these kinds of situations. And there is a sense in which everything we've talked about in terms of how culture might be playing into this could potentially be the same hypotheses for people who were born and grew up here in the United States, right? The idea that one might think that their duty to their parent is to advocate for treatment till the end, or that they worry about starvation if you withdraw a feeding tube. All things that a American citizen or third or fourth generation American citizen could think as well. We tend to bring it up in the context of a family who comes from a different culture as potentially we want to investigate that a little bit more closer, or a little quicker to investigate it, lest we might not be seeing some of their assumptions, that the family unit might have different kinds of bonds, or that duty of a daughter to a mother might be a little bit different in that culture. But again, not necessarily changing the way we treat them or what we investigate here. One of the reasons that this case bothered me so that it ends up being written up was because I was unable to do anything with this case. I mean, basically my whole contribution to this was supporting the physician and saying things to her like, medical ethics says you're not under any obligation to give a treatment that you believe has literally no medical benefit. And to back her up on things like that. And then she felt more comfortable negotiating because the ethicist was the hard ass and the doctor got to be the person who gave a little bit. But I got to talk to the daughters. The husband and son became very good at making themselves unavailable to talk to us very much more. And so I actually never got to speak directly to the husband and son. Eventually the patient passed away in the unit. And she still was DNR. The physician told them when they were threatening to change the goals of care if they didn't get their way on certain things, she said, we could make the goal extending her life. I got nothing that's going to extend her life, so nothing's going to change. If you want to rescind the DNR, we could do that. And they said, no, we don't want to do that. But in the end, it was just a very difficult case, and I got to go say to the doctor and the team, thank you, because I felt like maybe I could at least do that much, to let them know that we really did. Sometimes an ethics consult just says, yeah, you turned over every rock you could and looked for everything you had, and we got nothing. Thank you for doing that process and being as sensitive and caring. We have other hypotheses that we don't know how they played in. The daughters being discounted so dramatically. It was a female physician too, and we're wondering, does she hold as much weight with them as a male physician would? Things like that, but we just don't know the answer to that. So in the end, we were just able to be supportive of the team, and it played out as it played out, with being kind of a energy drain and difficult things. So just to go back a little bit, again, you folks are experts. Again, as I mentioned at the outset, we were going to surface things you already know and try to bring them to bear and make them systematic. We want to do everything we can to create a bond with a difficult family, not avoid them, make our supportive statements, explain as much as we can, let them know we understand this is difficult for them, bring to bear whatever resources we can, whether it's from pastoral care, case management, social work, ethics, and talk to them about the ways we want to think about this in terms of surrogate decision making, and make sure they understand there's a variety of ways to discharge those duties in ways good, dutiful sons and daughters and family members do. And then again, the one thing that's not on the slide is then thank each other for that. Tell each other you did a good job, that you really did everything you possibly could. If we can learn something from a particular case, we want to learn that. Sometimes we don't end up with a takeaway, but nevertheless, you cared for people. Sometimes the hardest people to love are the people who need our love the most, right? By treating them with that respect, even when they are taking more of your energy from you than you'd like that day. Thank you for doing that. So with that, I'll end. Thank you.
Please help me thank Dr.